Okay, so in this session, we're going to examine some of the treatment options that exist for treating lower back pain, or just back pain in general. Here are the learning objectives, and here's your drug list. I kind of streamlined the process for you a bit. I kind of grouped all these different drugs by first line, second line, kind of third line therapies. And so part of the clinical skills and part of the pathophys, we'll kind of look at, you know, how to kind of rate where, first line therapy should kind of be instituted, and how quickly do you have to kind of put the patients through these different lines of therapy, ultimately ending with opioids. So in terms of treatment of back pain, we're really talking about treating pain itself, analgesia. And what we're trying to produce is a kind of a loss of the ability to really kind of feel the pain while the patient's conscious. And we can't go into a whole bunch of hardcore mechanisms because that's basically neuro. So this is kind of an introduction to pain management. Understand that when we talk about pain, we're looking at several different targets. We're looking at opioids and alpha-2 receptors within the brain. We're looking at localized anesthetics as well as opioids and alpha-2 agonists within the periphery, as well as using some of these anti-inflammatory drugs kind of further down. And so the major drug classes include NSAIDs, opioids, steroids, and muscle relaxants. And of course, not in that order. They were just off the top of my head. Really, the best form of treatment of back pain, aside from getting that slipped disc kind of back into its location, is musculoskeletal strengthening. And so things like core exercises, so you see a couple planking and elliptical type machines are really good for kind of part of the physical therapy that goes along with kind of managing lower back pain. And I keep saying lower back pain because I'm actually a lower back pain patient. I have a slipped, excuse me, a slipped disc. And honestly, the only thing that really worked outside of a short course of steroids was strengthening the core and various elliptical type of activities for me. And so you've probably noticed I can stand straight up now. That was not the case just probably about a year and a half to 2 years ago. I was walking hunched over in a lot of pain. So we'll talk about how trauma and the perception of pain kind of exists in more detail in the next up and coming weeks. So this is more or less an introduction. So of course we're going to talk about NSAIDs. We've talked about them before. I'm not going to go into great detail. You can review the NSAID lecture here from the previous case. You don't have to go through the entire lecture, of course. I think you should focus on ibuprofen, naproxen, and of course obviously the non-NSAID acetaminophen. We don't really know where else to put it, so it goes there. These particular NSAIDs have been shown to be effective. The literature is conflicting on acetaminophen. If you read up to date and some of these other sources, they say acetaminophen is not a good drug to use for back pain. That's when they look at it used individually. Acetaminophen works really well when combined with ibuprofen, and yes, you can combine them. You can dose them 2 hours apart from each other. And also acetaminophen works really well with opioids, and that's actually the formulation of Vicodin. It's morphine, or actually codeine specifically, combined with acetaminophen. Okay, so if you have any questions on acetaminophen, please kind of go back to the lecture and review. Same as with steroids, kind of look at the steroid lecture. Of course, you don't have to go through all the steroids. The steroid I think that's most effective is probably methylprednisone under the brand name Medrol. It comes in a dose pack. I think it's 5 days of therapy. And these drugs have been used quite extensively in the acute back pain episodes. And they just did a Cochrane review, and the results were kind of less than stellar. But they for me personally, they worked very well. And I know a lot of people who have an acute back pain problem, and these drugs get them mobile, and they get them mobile enough to, and get a handle on the inflammation so that the patient can actually do some of the physical activity and some of the rehab type exercises to kind of pull those muscles and kind of strengthen that core to kind of support that back. All right. And so in terms of the first group of drugs that we're going to talk about, the muscle relaxants, we're going to have to get into some neurology and neuroscience, and we're just going to kind of briefly kind of highlight some of these parts. And so I like this diagram because it shows you kind of the inhibitory tracts and the corticospinal pathway and how it leads to a muscle. And then the drugs of choice, and we've already talked about some of these in other cases. So we talked about dantrolene already. In terms of back pain specifically, we're going to really focus on tizanidine, which is targeting the alpha-2 receptor, and I have more on that later. And we're going to leave baclofen because the results have been less than stellar, and we're going to leave benzodiazepines, both of which basically potentiate GABA, for another time. And so, you know, understand that this introduction that we're talking about is really kind of the tip of the iceberg. There's a lot more to this than we're going to cover in this mini lecture. But you should understand that what I've done is I've focused this lecture specifically on the current treatments for back pain and the ones that have been the most effective. And so there are other drugs that kind of fit within this lecture series, but we're not going to talk about them because they haven't really been shown to be more effective than the drugs that we're going to talk about. Okay, so we'll end here. This will be our introduction to back pain, and our first drug class will be the muscle relaxants. Okay.